Hello, good morning, everyone. I would like to warmly welcome you on this full day of endodontic knowledge. My special guests are Professor Matthias Zehnder and Professor Dan Rechenberg. Good morning, guys.
Hello,
Hello.
Hubert.
Dr. Zehnder, Professor Zehnder, is a tenured head of the Division of Endodontology at the Clinic of Conservative and Preventive Dentistry at the University of Zurich. He's a former associate editor of the IEJ journal, as well as a former editor-in-chief of the Swiss Dental Journal.
They kick me out everywhere.
Yeah. And Professor Rechenberg, he's a senior lecturer at the same division of endodontics at the Clinic of the Conservative and Preventive Dentistry at the University of Zurich. And he's also a member of the editorial board of the IEJ journal. Our today topic is very important and very innovative. The topic of our talk, of our interview, is precision in dentistry, biomarkers. And the first topic will be to Dan. Dear Dan, let's start with the basics. What exactly are biomarkers in the context of oral health, and why are they becoming relevant in clinical endodontics, in your opinion?
So, in endodontics, for a long time, we kind of live in the Flintstone ages in terms of, you got to knock on a tooth or you got to see is it loose or anything like this. So diagnostically speaking, we're hampered or limited to some degree. Of course, we have innovations like imaging technologies, like cone beam CT, but it would be nice to have actually things that correlate well with the disease. And that's exactly what a biomarker does in the medical field. So it is either a molecule or a gene that is expressed, and this is either only expressed during disease or to some degree correlates with the disease. And that would be very nice in endodontology to augment or use our this for diagnostic purposes.
As we know, proper diagnosis is the key for proper treatment in the future. Good, so the second question to Matt. Matthias, there's a lot of buzz around precision dentistry, right? How close are we really to integrating biomarkers into routine diagnosis and treatment planning in endodontics? How can we use it?
I think we're pretty far away from it because the problem really is that you always get a bias when you, for instance, collect the biomarkers from the cervical fluid, for instance. So you have periodontal disease or gingivitis that kind of overshadows what's happening in the pulp. So to get a biomarker from the pulp, you have to open the pulp. Once you open the pulp, you can use a microscope and see, how inflamed it is. I mean, we did some studies correlating biomarkers with outcome of direct pulp capping. And for instance, you can look into neutrophil biomarkers like MMP9, and it correlates really, really well with the early failure. So when you have a lot of, let's say, neutrophil markers in the pulp, which you don't see, same clinical presentation of the case, cases are going to fail early. So the research is there, it's published, but there is no chairside test. The problem with implementing these things is always if a test is more expensive than overtreatment, the test will not get to market. That's problem number one. Problem number two, in Europe we have the new regulation, medical device regulation, and so diagnostics is very regulated these days, so it makes it expensive for the companies to adopt. So no companies investing in it. So I think there's challenges from multiple aspects, but I mean the science is really there. You could develop a test, but the question is how expensive that test would be.
So we've got the science, and now we need to make use of them in the future with companies, right?
Yeah, you could see it that way.
We'll see. Good, so let's change the topic a little bit to clinical relevance and application. Maybe another question to Matt. Can biomarkers be used in the management of deep caries to differentiate between reversible and irreversible pulpitis, or even to anticipate the outcome of a procedure?
Technically, yes, you could do it. Question is again, when you do this kind of biomarker collection, I think Dan can also answer this question because he did some studies on different ways to sample. And the problem is always the yield, like the protein yield. So if you don't enter the pulp, which technically is good, if you have a deep caries, you don't necessarily want to enter the pulp. So we did some studies also with my friend Vasudev Palal, Manipal in India. So we showed that, when you have shallow caries in the same patient and deep caries, in the deep caries, without entering the pulp, you have more, for instance, neutrophil markers, MMP9, in the deep lesion. So it's possible, but again, it's a problem of the detection limit. So let's say the cheapest way to do a test would be a lateral flow assay, like a corona test. But for that, you need quite a lot of protein. So that exists, for instance, in perio, gingival cervicular fluid, you can do it because you get enough protein. From the caries, difficult. I mean, you could collect the caries, you could basically dissolve it, but show me a dentist who would do that. It's possible technically, but it's not practical. That is the problem. This whole biomarker research is really something between applied research in clinics and basic research to get some grant money. So I'm a little bit, even though I did the research myself too, I'm a little bit critical when it comes to what is the practical application of it.
And I just want to add one thing, because maybe our audience doesn't, who's not that much in that topic is aware. It's not one single biomarker we are looking at. Usually it's a subset, and we know that from a couple of good studies that the differentiation between reversible and irreversible pulpitis is possible to some degree. But again, that comes down to application, and this is at the moment where the problem is, just to give you an idea.
That's true. And now question to Dan. I can see how biomarkers may guide treatment planning for deep caries, but how could they influence decisions in conventional primary endodontic treatment or retreatment? For example, could they support a decision to reapply COH2, so calcium hydroxide, a second time or additional canal enlargement?
That is a very good question, and this question has been answered a long time ago, and we also are guilty on having a study on this. This is of course possible to some degree. The history in endodontics is this microbiology tests with paper points, and we also sampled periapical fluids, in acute cases, and we medicated them and sampled again, and we could measure that there is, of course, a different composition of biomarkers detectable to some degree. So this is, of course, a thing you can do. But honestly, now speaking as a clinician, we're moving a little bit more towards single visit, which is justified based on the literature. But for some cases, it might be a very useful adjunct from my point of view.
Matt?
I may say something. I treat a lot of chronic pain patients. And I see an application for that group of patients because they're convinced that, I get these cases that persistent pain, but there's no inflammation. So if you have a molecular test, for instance, periapical fluid, that is enough fluid to do a proper test. So you could use that and show the patient, look, this is not inflamed. So your pain doesn't come from the tooth. I find that could be a very useful application and also feasible, technically feasible to do. So I would not go into the everyday case necessarily, because the dentists have enough experience to see, okay, this caries is so deep and there's symptoms, this is the patient. Depends a lot on the patient. But I have a lot of these difficult patients. So if I had a test to show them, look, this is not really inflammable that much. Not today. You still have to do a cone beam. Say, okay, there is no lesion. There's nothing. But what does it really tell you? Nothing. But if you had a molecular fingerprint from the periapical fluid, that could be something. I don't know how you see that.
Dan?
What you describe is exactly what I do, just without the test. I'll tell you.
Thank you, Dan.
Just kidding. No, absolutely. I think for this subset, for this group, that is certainly a thing, because it's in the head of the patient that this comes from a tooth. It started with a tooth, and every way to prove that this is not the issue, is very warm welcome. And I know there are studies performed in this in Zurich at the moment, so that is a very, very important topic from my point of view.
Yeah, we're doing a study on crevicular fluid in chronic pain patients. Like they have like a tooth that hurts chronically, but it's not inflamed. And so we do like a proteomics analysis of all the peptides that are present, just to see maybe is there something, because of course the same nerve that goes in the pulp goes in the periodontium. So that could be something. I think there is areas that are non-research that could be evolved and
further research.
Yeah.
Studies.
Also, even to understand the disease process or to understand the condition. So.
Good. So another question in the same area of clinical relevance and application to Matthias. Which specific conditions or scenarios do you see as the first realistic targets for biomarker-based decision making? For example, irreversible pulpitis, pulp regeneration, or periapical pathology, in your opinion?
As I said, periapical sampling, I think with a paper point and then having a lateral flow test, I think that is something, because single visit versus two visit, of course, when you clean the root canal well, there is now a test that is tested by, I think, Henry Schein. They have it that they want to test whether there's still traces of bacteria in the root canal or not. That could be something. I mean, it's about to, at least some companies are now evaluating this. But the problem is a little bit then when you do single visit and you use like a sealer that has some antibacterial properties, you may still be successful. So I don't think that it's going to fly with a dentist. You also have to always realize when you want to commercialize something, who is your customer? Your customer is the dentist. You're not going to sell it in the pharmacy to a health-aware patient who have an Apple Watch and a ring. You still have the ring? No, the other ring, your health ring. You know, so these, of course, to people like Dan who care about your health,
Still have the ring.
It's easy to sell. To dentists, it's not that easy to sell. You see, so that's a little bit the problem also, commercially.
Dan, would you like to add something?
Just a quick reflection. I just confirm what Matt says. I think the periapical, that's the most applicable right now. Actually, there is already a test in the US marketed, I know, on ATP. However, you know, maybe we can at some point talk about limitation of this test too, because they need to be properly evaluated. We need to define thresholds for those tests, and I'm not 100% sure if this is there at the moment.
So let's talk a little about sampling and methodology challenges. So Matt, apparently different biomarkers serve different purposes. Some distinguish between reversible and irreversible pulpitis, others identify inflammation levels or symptomatic cases. With so many potential biomarkers, are we still a long way from having a standard diagnostic treatment protocol? Do we have to wait a long time, or maybe it's just there? Dan, maybe?
Please answer, Matt.
Yeah, I think
No
we
opinion.
pretty much covered it a little bit before. I mean, there's like when you do this type of research, there is two questions. There's two approaches. You can do a targeted approach, which I did like in my early studies. I just looked at MEP9 because I know from histology, from Rikuchi, from other guys, okay, it's the neutrophils. It's the neutrophils that dissolve, that digest the tissue that make the pulpitis irreversible histologically. So it's you can look for neutrophil markers, but then you can also run an open approach, doing a proteomics approach. So you look at everything that's there and correlate it to your clinical outcome. Because you have to, the question is also always, what kind of biomarkers are you looking for? I think clinically we're looking for what is called a predictive biomarker, so that predicts the outcome of the treatment, So that's not the same as like a prognostic biomarker, which just looks at the disease and how it kind of progresses. So you're looking for that, and I think the biomarkers, as I said, is no rocket science. Just look for a neutrophil biomarker, and it's been published. It can be commercialized. Do people want to commercialize it? I don't know. I mean, there's this Timo Sorsa from Finland, who has the patent, who actually detected the MMP8, neutrophil collagenase, And he has these tests, that are in the market for curricular fluid, for even for oral rinse samples and so on. Yeah, and there's some in the periodontal research. There's some good success to that.
Right?
And in endo again, the test is probably not very practicable. But plus also he has this reader and a lateral flow test. There's not enough yield, and so
You know, it depends. I agree on this partly. It depends on the question you're asking and what's in stake for the patient. We're nowadays, the concept of root canal treatment is kind of challenged by simply treating the pulp and not removing it completely in terms of vital pulp treatments. And at the beginning, I still remember, it's now 10 years or something like this ago, even longer, we envisioned a little bit, for instance, a test that may differentiate between a reversible and irreversible inflamed pulp in terms of that if you have a deep caries lesion, you take away that caries, you sample, you restore the tooth, you send the patient home. And you have time to analyze it, and if you then can calculate out of this or measure out of this a likelihood for this tooth to become acute, that would be a great service for the patient. And I feel like I personally as a patient would pay for this because I want to know, okay, how likely is that working out? Because this is something I see in my clinic a lot, that patients come, they get deep fillings. It's okay for a couple of days or even weeks, but never turns down. And if you can measure this, that would be a very nice application.
We have a publication in the Journal of Endodontics, I think 24, where we looked at the long-term outcome of direct pulp capping, and the MMP9 that we sample from the pulp wound correlates very strongly with the early painful failures and not with the late failures. But the thing is this, why don't dentists do direct pulp caps or other vital treatments? Because they fail painfully. If they fail painfully, the patient is going to be angry at you and say you did the wrong thing. So if the case fails non-painfully, patient doesn't necessarily care. You can check at the recall and say, okay, this tooth developed a lesion.
Pain is the key for the patient.
So what? You do a root canal. But I think it's the early painful failures, and those you can test. Those you can predict. So I think our studies there in this context are kind of important. Of course, nobody noticed because nobody reads papers these days, but it's you could commercialize this idea and pitch it even to dentists, because that's something every dentist understands. That's actually the reason why they avoid vital pulp treatment. It's now a huge topic, vital pulp treatment, or vital pulp therapy, as Americans call it, but they don't speak the language. So,
Good, so we've got only 5 minutes left. We are confined in time. And so let's have a little insight into the future, the future outlook. So the first question will be to Matt. What are the biggest challenges today, scientific, regulatory, or clinical, in making biomarkers part of daily endodontic practice? So I think we covered it a little bit, so it will be regulatory, right? And to commercialize the science that we've got already right now. Right, would you have to add something?
Yeah, it's usually if you look at what dental companies now put out as new products, just walk around here, not that many new products. You can ask yourself why. How commercially interesting is it to have tests like that? That's the main question. And I think we pretty much answered the.
Yeah, that's true. That's true. So the last question will be to Dan, and finally, looking ahead, if we meet again, for example, in 5 years, right? Maybe during next ESC meeting, what would you hope to have achieved in terms of biomarker integration with dentistry? What could be done in 5 years in this topic?
So actually a couple of things. One thing I would like to see, that is, after all, an interesting research topic. And you take a look at studies published, there are many studies just analyzing tissues or something like this for some mark, but there's only very few groups work a little bit more targeted into this specific dental application direction. That would be maybe a call for the younger colleagues to pick up this topic, because it's important, and then everybody asks what's the future. From my point of view, this is one thing of the future, and in terms of application itself, I mean, we talked about these regulation issues. I feel like even the industry should find a modality to foster or to advance the aspects. And in 5 years, honestly speaking, I see not a breakthrough, but hopefully constant development
Little
into
steps,
the
step by
exactly into the right direction, and maybe analysis with AI and things like this. This is not really investigated in that area, at least not in the dental field. So maybe this can even work with multiple subsets of markers and help to advance a specialty into this diagnostic thing then, because we have an issue, honestly speaking. That is, it's not perfect what we do right now.
Matt, you would like to add something?
No, he said it
No?
all. He said it all.
Good. So thank you very much, guys, for this nice time
Thank
we
you,
had
Uber.
here. Thank you very much for participating, and see you later today. Bye.
Thanks a lot.